But one thing I think that we would agree upon, and this is not dependent on myopia control, is you have to believe in the technology. Like you can buy an IPL, and if you don't believe in it, it's going to fail in your office. So like
Hmm.
whatever you implement, you as a clinician have to buy into. You truly have to believe it works, because whether you're focused on the experience or making the lens fit the best, or get just like whatever your focus is, if you believe in it, then you just the way you speak about it is just going to be so much more high level, and patients are going to connect with it. Patients can tell if you're just doing it to sell them something.
Hmm. And with as Joelle described you with a more academic approach, does that fit into, is there a different like fitting philosophy between the two of you? Like, is there different demographics of patients? Are there certain patients that one of you will touch and the other one will not, as far as like how you fit? Like, are either like software design or empirical or trial set? Is
Mhm.
there a difference in the way that you're fitting lenses?
I don't, well, I don't know. We probably don't talk too much about that. I think our patient population is maybe a little bit different, um, primarily because Joelle pulls patients from her primary care practice, where I pull patients based on referral and or word of mouth. And my core population is much more Asian, which in Minneapolis is like a low density population. Um, as far as I think we fit a lot of the same lens designs, and I don't know, Joel, we haven't really spoken about that. I bet our fitting philosophy is relatively more very similar.
I think, yeah, I definitely think it's similar. It is interesting on our patient populations. I don't like mean to like put demographics into like little buckets or anything, but like Zach sees a lot of Asian patients and he works in an academic setting. So I feel like that parent loves that type of technology, that sort of like research. I think as a student comes in and sees the patient, and then Zach comes in and sees the patient, and then Zach's talking to the student about like what he, like these parents are kind of overhearing like the fitting, like all of the things I don't ever say out loud because I don't, the parent doesn't really need to know all like the intricate little details of the topography or the eccentric value, any of those type of stuff. But he does. And maybe that's a little bit of like how he's built his patient population the way he has. I have a very low, I mean, we're 20 minutes away from each other. Like I have a very low population of Asian patients. I have a ton of Eastern Asian. I have like Indian patients. I have a lot of just Caucasian patients. And I would say like maybe 5% of my population is like Asian patients. So it's really interesting that we like differ so much in like demographics. But I think our fitting philosophy is probably very similar. I am like game for anything. Like after what I've seen, um, like Mark Cosgrove, like to me, really like expanded my brain a lot on what, like who I can fit. Cause I feel like he was always like not a crazy like wild wild west cowboy, but just kind of like let's try it. Like why can't we try
Hmm.
it? And so I was like okay. And so of course always like managing the patient and making sure I'm watching like all the anatomy. And I have taken a couple patients out, but like I mean I've got some -10, -4 still, like some crazy stuff that I feel like I would have never read or like heard anybody talk about, but it works. And so I've done very few like truly topography guided like wave stuff. Like it, to me, that's cool, but that might fit in the academic setting a little bit more. Like I don't have the time for that. And I just don't know if I even want to know how all the little balls work and how all that stuff works. I love like empirically fitting. That's probably what I do most of the time. Not that I like need to sit on one company more than the other, but between Euclid and Doctors on Design, that's probably what I use the majority of the time,
Hmm.
because their online software is super easy to use. I can just order right on their software. It goes in, a lens shows up at my office, and I'll call for consultation if I need it. But I love that part of it, especially being in a private practice. I'm like, I don't want to be sitting and like imagining it up myself. Like
Right.
that's what we use good lens companies for. So I think our fitting philosophies are really similar, but it is interesting on our like patient demographics are quite different.
I was going to say, I think you want to tailor your program around both your practice and your patient expectations. Like we haven't said it, but my clinic's name is the Cornea and Contact Lens Institute of Minnesota. And so in practice, when patients show up to come to that practice, they are not exactly expecting a family practice type of environment. And so you just have to meet your patients or build your program in a way that their expectations are met. And I think that that's kind of a really neat dynamic that Joelle and I are both like trained to the same level and can both fit the same complexity of patients, but she does it more within a family practice clinic, where I do it more within a like teaching institution situation.
If you're interested in getting the rest of the episode, consider becoming a paid supporter of the Myopia Mindset. In addition to an extended version of this episode and every other episode that we do, you'll also get access to exclusive monthly bonus episodes of the Myopia Mindset. And I know you're interested. You've made it this far. You can do so on our Substack, myopiamindset.substack.com. I'll see you at the next one.